Hello friends, today we are going to discuss about approach to a patient coming with an acute respiratory distress syndrome, that is coming with a severe breathlessness. Now to start with, when we encounter a patient having an acute respiratory distress, we should keep some common differential diagnosis in mind before starting our diagnosis. And these common cause of acute respiratory distress are acute left ventricular failure, spontaneous pneumothorax, acute bronchial asthma, acute laryngeal obstruction, acute pulmonary edema, cardiac tamponade or pericardial effusion, anaphylaxis, and hysterical or psychiatrical hyperventilation. So these are some common cause of acute respiratory distress. Now to start our diagnosis. To start with, we will start by history. As we know, all history have three basic components, that is onset, progress and duration. In short, OPD. Now to start with onset. It has been found that almost all of the above causes are acute in onset except for the bronchial asthma and hysterical hyperventilation, where onset is usually found to be gradual. Next come the progress. Same is true for progress also. Only for bronchial asthma and hysterical hyperventilation, progress will be gradual, and for all other, the progress is acute. Now come the history of chest pain. If the patient complain of chest pain history, then you should keep in mind the pneumothorax. We will also ask the patient about ingestion of any foreign body or taking some drug, especially the penicillin group of drug, in which case we will going to suspect anaphylaxis. And lastly, we will going to ask patient about their any psychiatrical disorder for which they are seeing a psychiatrist, etc., or any emotional problem he is facing currently. So this concluded our history. Next come the examination. So what we will going to see on examination? First, we will going to notice if patient have any orthopnea or cyanosis, which will going to lead us towards cardiac cause of respiratory distress. Next we will see the cough, which is usually present in pneumothorax, left ventricular failure and foreign body. Thirdly, we will going to see the pulse, in which if we find there is a pulsus alternus, then we may suspect LVF, and if we find pulsus paradoxus, we can suspect acute severe asthma. Next we will going to see the JVP or jugular venous pressure, which is usually found to be raised in cardiac tamponade, left ventricular failure and right ventricular failure. Next come the BP, which can be found high in LVF, but not necessarily it will be high in all case of LVF. Next come the urticaria, which is usually, if found positive, makes our diagnosis towards anaphylaxis. Next come the percussion. On percuss, if we found any part is dull, then we can suspect the pneumothorax of that site. Similarly, if we find that the liver and cardiac dullness reveal the obliteration of liver or cardiac dullness on the cases, then we may suspect acute severe asthma or COPD. Next come the auscultation. which is the cornerstone of diagnosis in severe respiratory distress. First, we will going to discuss case by case. If it is an LVF, then what we will found? We will found that rhonchi is present, crepitation will be found, gallop rhythm will be found, vascular breath sound will be present with the vascular or vesicular breath sound will be present with prolonged expiration. Next comes the COPD or acute severe asthma. In this case we will found the rhonchi, and the degree of rhonchi will be much more in comparison to the rhonchi in LVF. Similarly, crepitation will be found, but the intensity of crepitation will be lesser than that of crepitation found in LVF. And we will also found the heart sound, which is muffled. Sometimes it may present as a silent chest. Next comes the anaphylaxis or acute pulmonary as a thromboembolism. In this case we will found a vesicular breath sound with prolonged expiration and occasional rhonchi and pleural rub. Next comes the spontaneous pneumothorax. In that case we will find a diminished vesicular breath sound or even absent of breath sound on the affected side. Lastly, the cardiac tamponade, in which we will see or hear the heart sound is muffled. Next on our list comes the observation for any stridor or wheeze. If the stridor is found, then our diagnosis point towards anaphylaxis or laryngeal obstruction. And if wheeze are found, then we will suspect all other reasons except for anaphylaxis and laryngeal obstruction. And in lastly, if the hysterical hyperventilation is found, how we will going to recognize that it is an hysterical hyperventilation? We will see that there is a pause in inspiration and expiration. That is, there will be a pause between an inspiration and expiration, and there will be no cyanosis peripherally, and it will be noticed that the breathlessness is exaggerated in presence of relatives and stranger. So this concluded our physical examination. Lastly comes the investigation. In investigation, our main source is chest X-ray, usually PA view, that is posterior anterior view, and the X-ray of neck, that will give us foreign body, and blood gas analysis to diagnose the other drug induced cause of acute respiratory distress syndrome. So this concluded our discussion on approach to acute respiratory distress. From here we will going to discuss case by case the management of different cause of acute respiratory distress. Thank you.